Everybody, welcome to the University of Toronto Joint Centre for Bioethics seminar series. Thank you for your patience as we got everything up and running. I'm Catherine McDonald, Knowledge Translation Specialist at the Alliance for Healthier Communities.
If you want to do that, you can do via Zoom.
And I'll be the moderator for today's seminar, which is co-presented by Women's College Hospital Institute for Health.
Catherine, you've been muted inadvertently.
My apologies, can you hear me now?
Yes, perfect. Continue.
Thanks again for your patience. Our speakers today are Sara, Bhatti, Shivani, Chandra, Dara Gordon, Ciro, Muiruri, Rayner, and Jay Shaw. Their seminar is entitled Overcoming the Digital Divide, Enhancing Equity in the Health System. Before I fully introduce them, I'd like to let you know that the seminar is being recorded. This lecture, along with other archived lectures, can be accessed through the Joint Centre for Bioethics website. Next slide, please. A quick note about housekeeping. To minimize interference and background noise, we are keeping your lines muted, but we do want you to participate by asking questions. Please type them into the chat panel. Our team will be watching and compiling them during the presentations, and then we'll ask them on your behalf during the Q&A period. You can continue submitting questions throughout the Q&A period, and we'll get to as many as we can. I'd like to also take this moment to remind our panelists to keep yourselves muted during each other's presentations and to be unmuted during the Q&A so you can jump in and answer if appropriate. Finally, I'd like to remind everyone that we are recording and will be sharing this with registrants in the coming days. So on the screen, next slide, please. On your screen, you should be able to see the agenda for today's seminar. The format is a presentation by our speakers, followed by the facilitated discussion period. Now I'd like to call on Dara Gordon, who will start us off in a good way with a land acknowledgement.
Hi there, my name is Dara Gordon and I'm a settler living in Toronto. I'm one of the co-chairs of the Equity Committee at WEAVE, which stands for Women's College Hospital Institute for Health System Solutions and Virtual Care. So if you hear us using that term during the webinar, that's what we're referring to. My other co-chair is Shivani Chandra, and she'll be speaking later on in this session. So WEAVE's Equity Committee seeks to advance health equity as a strategic priority and outcome measure across WEAVE's portfolio, which is a goal and alignment with the greater efforts by Women's College Hospital to also promote and advance health equity. As a brief overview, today's webinar will present a few pieces of related past and ongoing work being undertaken by WEAVE's Equity Committee and researchers at the Alliance for Healthier Communities to advance equity in virtual care and digital health. Both groups have set our sights on understanding and addressing the gaps associated with access and utilization of digital tools for certain populations, with specific attention to the needs that have arisen as a result of the pandemic. But before we begin, I'd like to take this opportunity to acknowledge the traditional territory of the Indigenous peoples who inhabit this land and who share their home with us. In this acknowledgement of land, I'll use the term Indigenous to refer to several nations of First Peoples in Canada, but it's important to acknowledge that this is not a term that all Indigenous people identify with. What are referred to as land acknowledgements have become more of a mainstream practice at the beginning of ceremonies and lectures since the Truth and Reconciliation Commission of Canada published the 94 Calls to Action. And taking the time to acknowledge the land is considered a step in the right direction to honor those present and past with whom we share this land. But it's important not just to read an acknowledgement out of rote obligation or as a token gesture. The ethos behind acknowledging the traditional stewards of the land is to think deeply about where we're situated and how we came to be here, and to signal commitment to action towards repairing relationships with Indigenous populations through reconciliation. So let's talk about a few of those things. To begin with, at Women's College and At most of the institutions, organizations, and agencies represented on behalf of the attendees of this webinar, we like to consider ourselves pretty forward-thinking. But regardless of our best intentions to promote equal access to healthcare, develop meaningful digital tools, and ultimately do no harm, we have to remember that we work in organizations that are part of our colonial past. And for those of us who are settlers on this land, meaning that we are not First Nations, Métis, or Inuit peoples, our collective understanding of how Canadian society operates and what it seeks to accomplish is imbued with values that came to Canada during the period of colonization. For many of us, these ideas have become normalized, which means that they have become invisible to us, and they include things like ownership of property or our emphasis on individual autonomy over the role of communities and families. But we don't often consciously remember that these values have permeated within our society as the direct result of efforts to strategically eliminate Indigenous values or worldviews. This is history that we need not shy away from, though. It is fact. But we must consider and embrace the ramifications of this history, because when we work with or deliver services to Indigenous populations, we are still doing that work from behind desks, virtually for many of us, on behalf of organizations that are, hospitals, schools, banks, offices, government buildings, which descend directly from that era and from those efforts. In fact, colonization in Canada includes a dark history of Indian hospitals. For those who are unfamiliar with this part of our history, Indian hospitals were often old military quarters repurposed as hospitals, which lacked most basic hospital facilities, where Indigenous populations were forcibly detained and isolated, and on whom medical and nutritional experiments were performed. In understanding this context and the values and practices that our current society was constructed on, it becomes very clear why many Indigenous communities might resist care from physicians or experts inside these walls. It is a privilege to be able to think about equity and to do the work that we are talking about today in this webinar, because equity is not something that has been achieved for everyone. We're so grateful for your open-mindedness and your willingness to work with us on planning how to make digital tools beneficial to everyone in our society, not just some, especially during the pandemic. The work that we are undertaking is a conscious shift towards thinking beyond our own worldviews so that we can understand the worldviews of others and to respect their experiences as we come up with ways forward for digital healthcare together. Reconciliation is about understanding that the biomedical model of health that many of us venerate does not define the apex for health for Indigenous populations. And it is about inviting Indigenous people to co-create this work, listening to what Indigenous populations need, and finding ways to meet those needs together. In that spirit, I'd like to express my gratitude to Elder Constance Simmons and Tina Kinney-Brown from Women's College Hospital, who have guided our learning, taught us about offering tobacco, and shared resources with us, including work by Selena Mills, who's also from Women's College, about these issues and topics. Through our conversations, I reflected on my relationship with this land. And I was born here and raised in Toronto, and all of my memories are grounded in this city. From Center Island, where I grew up spending summer days, to the downtown streets of Toronto, where I now work and live, I'm lucky to call this place home, and I'm grateful to the many Indigenous peoples who came before me and those who continue to endure on this land and take care of it so that others are able to experience it. And with that, I would like to acknowledge Toronto, where the presenters of this webinar are located, as a traditional gathering place for the many Indigenous peoples of Turtle Island. I want to recognize the ancestral and traditional territories of the Wendat, the Anishinaabe, and the Mississaugas of the Credit First Nation, and the Haudenosaunee, whose territories and nations therein we are gathered on today. Thank you.
Thank you, Dara. Next slide, please. Now it is my pleasure to introduce today's speakers. Sara Bhatti is the Research and Policy Analyst at the Alliance for Healthier Communities. Shivani Chandra is the operational lead for the Health System and Policy Innovation Stream at Women's College Hospital Institute for Health System Solutions and Virtual Care, or WEAV, and a co-chair of WEAV's Equity Committee. Dara Gordon is a PhD student at the Institute of Health Policy, Management, and Evaluation at the University of Toronto, a policy research coordinator at Women's College Hospital Institute for Health System Solutions and Virtual Care, and a co-chair of WEAV's Equity Committee. Ciro Muiruri is a speaker, refugee advocate, and educator. Her organization establishes schools and community development initiatives in Kenya. Rayner is the Director of Research and Evaluation at the Alliance for Healthier Communities. And Jay Shaw is a scientist at Women's College Hospital Institute for Health System Solutions and Virtual Care and Research Director of AI, Ethics, and Health at the University of Toronto Joint Centre for Bioethics. Next slide, please. And now it is my pleasure to turn you over to Jay.
Thank you, Catherine, and hello, everyone, and thank you so much for sticking with us as we sorted out how to deliver this session and engage in some dialogue with all of you. So I'm going to be talking about one of the kind of core pieces that motivated us hosting this particular webinar, which relates to a symposium that was held about 1 year ago today, and the discussion paper arising from that symposium, which was just recently released. So digging right into the content of the topic for today, I'm going to start with some background material, which really centers around this notion of the digital divide. I will describe the symposium that we hosted, and then I'll outline some of the findings from the symposium. And we've established findings in kind of two different sections. The first is about the thematic groupings, the key insights that arose from the dialogue that we held. And the second is about the key policy implications. So those policy implications we're actually putting at the end of the webinar, and we'll be presenting those along with a number of the insights and important advocacy work that the Alliance for Healthier Communities has been leading recently as well. And then, we'll transition right into a discussion with Ciro, who was recently introduced, which will be moderated by Shivani Chandra. So I'll move on. So in terms of background, this is an infographic that comes from Statistics Canada, and the reference, the way to find this kind of infographic and the study on which it was based is in the subsequent couple of slides. This infographic shows a few insights about digital technology use in Canada, and we'll start with the big number on the left of your screen. 91% of Canadians used the internet in 2018. So this is 2018 data, but we actually wouldn't suspect, despite the pandemic, that these numbers have changed all that much. And the reason for that is something that we'll be discussing shortly. So 91% of Canadians use the internet, and importantly, that means 9%, about one in 10 have not used. 10% have not used the internet in 2018. So I think, even at first, just understanding that 10% is a lot of the Canadian population, and that's the proportion of people in the country who, have not been documented, have not reported using the internet. So of the people who do use the internet, 78% sent messages using an instant messaging app, 52% made online voice calls or video calls, 75% used social networking websites or apps. So, very likely those 52% online calls or video calls, that has probably changed as a result of the pandemic. But, this gives an important kind of high-level overview of the degree to which the internet and the technologies associated with the internet are used in Canada. Now, from this same internet use survey, we'll look at just two dimensions here. One is income on this slide, and the next is education on the following slide. So what we're looking at here is a table that shows the users in the highest income quartile, so the highest fifth of income among the Canadian population, and the lowest quartile, the lowest fifth of income. And we're looking at a number of observations about the type of internet service and technology that's available to these people. So if we look at having access to the internet at home, you can see in the highest income group, it's almost 100%, virtually everybody in that group. In the lowest quartile group, it's 80%. You know, and this is important. That means that 20% of people in that group do not have the internet at home. So, you know, this is a representation of this idea of the digital divide that we'll be discussing today. I've highlighted a couple of other examples, having a smartphone for personal use, and importantly, using government services online. You know, of people in the lowest income group, only 62% have used the government service online. That would have real implications for people's predisposition, willingness, you know, knowledge about how to access emergency relief funds during the pandemic, for example. And then if we look at education, what we're looking at here are activity related to digital skills. And we're looking at the highest education group and the lowest education group, that being high school or less. And I'll just, you know, illustrate a couple of these. The third highlighted bar from the top, having downloaded files from the internet to your computer or other device. So people with high school or less, you know, only 43.5% of people have reported having done that. Something that, at least in the course of my daily work, seems very natural. And then connecting a new device to a Wi-Fi network. So, you know, you start to see in Canada that these disparities do exist. So, you know, what's the observation we see in Canada arising from that data and other studies? Technology is becoming more pervasive, of course, but not in equal ways. And this points to the central notion that relates to the work we're discussing today on the digital divide. So the digital divide is a pretty complex idea. We won't discuss it in too much detail, other than to say that it tends to have these be understood in these three layers. The first layer is simply about having internet access, having a device that allows you to access the internet, and the infrastructure providing access to the internet. And I saw there was a CBC News article just this morning outlining the implications of a lack of access to the internet in Canada, especially among First Nations communities. The second layer of the divide is about digital literacy, knowing how to navigate what you need to in order to find the information and do the things you'd like to do online. And then the third and kind of final layer of the divide is about translating that access and literacy into outcomes that matter for you. So these are the sort of dimensions of this idea of the digital divide. Now, you know, enter a pandemic at least here locally in March of 2020, and this issue becomes all the more pronounced. We can see across, you know, the research community internationally, there's been a huge growth in interest in this topic, the digital divide, what it means for health and healthcare during the pandemic. The American Journal of Public Health published this paper at the top of your screen called Broadband Internet Access is a Social Determinant of Health. And now that reality is becoming, you know, more clear than it ever has been. These are a couple of other screen grabs of some important work that's been done, some of it here in Toronto, other work internationally, illustrating the important dimensions of this topic. You know, and of course, back in March, our Ministry of Health in Ontario issued these new billing codes to make virtual care available and functioning in a way that it never has been before. This is an old story now, and you know, I'm sure what's driven many of your interest to attend today is this very fact that there is far more virtual care reliance on video visits and other kinds of digital technologies as a direct result of the pandemic. So this is happening. We know this is happening. We know this divide exists. What specifically are the challenges? What might we be able to do to address it? And this leads to the very last idea of background I'll describe before getting into the symposium itself. And this is this notion of intervention-generated inequalities. This was really eye-opening for me when I learned about this concept. This is the idea that innovations can actually cause disparities in access to care and cause disparities in access to outcomes, because particular groups of people may not be able to accrue the benefit from those innovations that others do. One of the comments in our symposium that rang really true is that innovation tends to go up market to people who have money and can pay. And that idea will figure later in this discussion as well. So intervention-generated inequalities. How can we ensure that reliance on digital health and virtual care does not exacerbate, worsen existing inequalities? And, in fact, how might we be able to leverage these technologies in ways that are equity enhancing? So that leads into a discussion of the symposium. This was a collaboration between Weave, which has been described to you, and the Joint Center for Bioethics at U of T, University of Toronto. The goal of the symposium was to generate insights into opportunities and challenges posed by digital health as relates specifically to the goal of advancing health equity. It was run with Chatham House rules, which means nobody's identity would be linked with anything that was said. And we had people taking detailed notes so that we could essentially, produce the insights that we're here talking about today. We had 62 attendees, and that was a multi-stakeholder group, including technology vendors, policy stakeholders, patients and community members, healthcare providers, researchers, and others. The symposium included 3 panels: people with lived experience, success stories of inclusive innovation and Indigenous health, and then breakout sessions to discuss what this means in particular ways. For the new initiative around integrated primary healthcare teams in Ontario, called Ontario Health Teams, working with vendors, technology vendors and companies, and doing community engagement in meaningful ways. So I'm going to jump right into the findings, and there are 5 findings, and I'll just discuss each one of them really briefly. Again, we'll be revisiting the policy, what this means for policy toward the end of the webinar. So the first kind of important theme that arose from the discussion is that technology is becoming more pervasive, but not all communities have equal access to connected digital devices. And this is really partially what motivated our digging more deeply into this notion of the digital divide, trying to understand how it becomes manifest, in healthcare and in public health here in Canada. The second is that not all problems are best solved by technology. And in some of our discussions with people who have been, working to innovate and deliver care, particularly for marginalized communities in the context of the pandemic, we've heard this loud and clear. Virtual care, it has its uses, but there is real in-person care that is urgent and life-saving, and that includes, community-based care, being out in the community, working with some particular communities. So if we look at an example like housing, there's a housing crisis. This is not something that can be addressed by technology. So just an encouragement that we keep our perspective broad and not become overly focused on technology itself. Third, technology should be designed with underserved or marginalized communities. And there's a whole body of work on this as well, the concept of universal design or inclusive design. These are approaches to design that have been pioneered to address exactly the topic that we're talking about today. So I won't say too much more about that. Shivani will be sharing an effort to keep underserved communities in mind, even in a time crunch like we experienced in the pandemic, when looking to improve technology and the services they support. Fourth, policy and procurement should focus on real needs. This was a really important point and refers back to the statement I made earlier about how technology tends to go up market. In the writing about innovation, the way in schools of management and sociology, the way that people think about innovation, one of the specific categories of innovation is opening up new markets. That means essentially creating a need that people didn't know they had. So it's important, in an equity enhancing approach to technology, one of the themes that came up is that the health systems in Canada already have real needs. We don't need new ones. So when thinking about the policy structure and procurement strategies for these technologies, we should emphasize on the real problems that they address in the health system. And then fifth and finally, the fundamentals of a digitized health system need attention before digital health can meet its potential. And this is kind of at its root about electronic health records and information sharing policy. Now, that's something that is is being changed, is evolving around the world, and across jurisdictions in Canada. And getting those foundations right is really fundamental in order to see the benefits, the real benefits that can accrue from using digital health technologies and virtual care. So the policy implications of this, as I said, will come at the end. I'm going to pass this over now to Shivani to introduce the discussion with Ciro.
Thanks, Jay. Thanks for joining us, everyone. I just wanted to, before we get started, also add to Ciro's bio that Ciro is also a board member of Sojourn House, which is a refugee shelter in downtown Toronto, where she was also previously a resident. And Ciro, I'm not seeing you. Oh, there you are. So I guess let's just dive right into it. So it's great to see you again, Ciro. Maybe to start, could you tell us a little bit about yourself?
Thank you, Shivani, and nice to see you as well. So I arrived in Canada as a refugee in December of 2015. I've settled down well in the last 5 years. And by day, I work for Infrastructure Ontario in their legal service department. And by night and every other waking hour, I work for Pendo International Projects, which is an organization that I established in 2018. And our main focus is in developing projects in Kenya. Specifically, right now we have a school that we established and opened in 2019. I also speak in various forums related to women, children, and refugees. So that's a bit about myself. Thanks.
Thanks, Ciro. And so in a previous conversation that we had, you had described the challenge of having a phone, but not having easy access to the internet when you arrived to Canada. Could you tell us more about that?
Yeah, sure. So I had a cell phone when I arrived in 2015. I was staying in a shelter, Sojourn House. The phone was not very useful anymore upon my arrival because I now needed a plan in order to use it. I was surprised later to learn that I needed a home address, I needed a credit card for monthly auto payment, and this is unlike Kenya, where you just buy a SIM card, insert it in your phone, and pay as you go and as you use it. So it took a while for me to get a plan. And when I finally did, I got the cheapest possible plan, which only happened to work in Toronto. If I left Toronto, it didn't work, and the data was very limited. I ended up having to rely on free Wi-Fi in malls whenever I could, which was not always convenient, especially in winter because I landed in December, very cold. So at the shelter, we had only one computer that was always busy, one computer with so many residents. So accessing it was always a challenge. So that is just some of the challenges that I had. And digital health for me was a whole new thing. At the time, we didn't have digital health in Kenya, and I didn't know how to use it. And it's looking back, it should have been some of the things that as a newcomer you are informed about because you don't know the services that are available. So at that time, I didn't know anything about digital health or how to access information. So lack of information was some of the challenges, despite now having a phone and being able to access internet here and there.
Yeah, thanks for sharing that. I think that provides a really, that experience is, I think, very important for us to hear, and understanding that, access can be very challenging for newcomers, and particularly in a time when we're all relying on digital health solutions so intensely, that's something that we need to continue to think about. So Ciro, my last question for you is, based on your experience, can you provide us with your insights on what impact COVID-19 and the widespread adoption of virtual care might have on a newcomer?
Yeah, so as a refugee and as a current board member of the same shelter that housed me 5 years ago, I can tell you that COVID-19 and accessing healthcare virtually is a huge challenge for newcomers, for homeless people, and for people living in the shelters. We saw most non-urgent doctor's appointments getting cancelled in March when the pandemic hit, and virtual care became the new norm, for lack of a better word. So challenges accessing devices like computers and cell phones and internet have been the order of the day for people who are new, jobless. So, and another thing is, even if you have some of those devices, accessing internet is a problem, because in my experience, I had to go to malls, like literally stay in a mall all day if I needed to prepare for my immigration documents, for example. So imagine now with all the malls closed, which means that even that free Wi-Fi in cafes and malls is no longer accessible because everything has been shut down due to the pandemic. And even when you get an in-person appointment right now, you cannot go with a caregiver. And some of these things are so challenging because of isolating yourself. For example, if you're self-quarantining and you need a caregiver to be able to either be with you as you access the virtual care from a doctor, is another challenge. And I'm not even sure how it's being done currently, but most people who come in from other non-English speaking countries need an interpreter. So I'm not so sure how that's being done, because previously you would go with your interpreter to an appointment, or when you get to your doctor, your interpreter would be called on the phone to interpret what you're saying. So I don't know how that's working right now. And some of the challenges of having virtual care is doctors end up missing subtle cues through phone calls, for example, because not everyone can access video or Zoom. And facial expression, reading your patient's emotion, and there's a certain connection that you have when you visit your doctor physically, or even when you are accessing virtual care, through Zoom and whatever other necessary platforms people are using. But then most people don't have that access. So the most accessible thing is cell phone. And through a cell phone, you will not know if someone, for example, says, okay, doc, I'm doing fine, but then there's tears running down their cheeks. So the doctor would miss some of those things. And the biggest challenge, and when you are a newcomer, when you're staying in a shelter, is mental health. So mental health, to begin with, is very limited, even when you are not staying in a shelter. And so accessing mental health right now during the pandemic is a basic need, especially when you're lonely, you're here alone, you miss your family back home, you have nobody here. And accessing mental health virtually is another big challenge, because again, you don't have that human, for lack of a better word, human interaction with the person who is giving you the care. So I can name so many challenges, but I know I only have 10 minutes. So those are the two that are coming out of my mind right now.
Yeah, thanks for sharing that. I mean, and what comes to mind for me is, I mean, if you're accessing Wi-Fi in a public space, and like you mentioned, a lot of those public spaces are closed, and you have some kind of, video visit that requires an internet connection, are you getting the privacy that you would need to have an open and frank discussion with your provider in a safe space? Yeah, so thank you so much, Ciro. These are all really, really important insights for us to continue to think about. And I really appreciate you sharing your experiences with us today.
Thank you so much. Yeah, thank you. And thanks for having me.
Thanks, Ciro. So for the next section of this webinar, I'll be describing the equity analysis process that we followed for a program at Women's College Hospital as an example of how organizations can apply the ideas identified in the Symposium report that Jay summarized in concrete ways. And so for that example, I'll be presenting the Women's Virtual Equity Assessment. So briefly just going over the overview of what this presentation will be going over. I'm going to be starting with the context of this project, followed by the process we use to execute the evaluation, including the framework we used for the equity assessment. I'll then walk through the recommendations at the end. And for the purpose of this webinar and the amount of time that I have to speak to you all today, I've kept the first two sections as brief as possible, and we'll be speaking about the recommendations more broadly. So if folks have any questions or comments about the process we used or the recommendations we generated, in this example, I'd be happy to discuss those in more specificity in the Q&A period at the end of the webinar. Next slide, please. Great, thank you. So to begin, I'd like to provide some context for this assessment and really explain what it was all about. And before I even start going through the slide, I just want to take a second to explain what I mean by women's virtual. So this was an equity assessment of women's virtual. And the Women's Virtual Department at Women's College Hospital leverages digital health tools and virtual models of care with the goal of making healthcare more accessible, responsive, and equitable, and it has several programs in its portfolio at the hospital. So Women's Virtual was launched pre-pandemic at the hospital in November of 2019. And as you can imagine, its programs were rapidly deployed in response to COVID-19. In that highly accelerated process, there was very little time to embed equity considerations into the programs. But in June, when things began to slow down compared to where we were at in March, the WEAVE Equity Committee was approached to provide an equity assessment of women's virtual programs. However, because of our team's capacity at the time and the hospital's desired turnaround time, we decided to focus our assessment on one specific project by Women's Virtual, which was video visits, where patients of the hospital have a video call with their provider as opposed to an in-person visit or phone appointment. And one thing that I wanted to note that isn't actually on this slide, but is that because we were asked to deliver our assessment so quickly, there were some important limitations in our assessment as a result. The biggest limitation is that we were unable to directly engage members of the community for their input, including patients of the hospital who had used video visits. That being said, 3 of the 4 members of our team had worked for months to provide support to patients who were having issues with their video visits. So we felt like we were able to use the knowledge of the barriers that we gained from the many, many conversations that we had to help inform our assessment. So moving on to that next column, so moving on to the broader societal context, as Jay described, the digital divide is a documented reality that describes the disparities between different populations and communities related to their access to web-enabled technology, digital health literacy, and tech-related health outcomes. Evidence shows that virtual care can exacerbate these disparities, but a growing body of literature in this area includes frameworks to support equity-enhancing deployments of telemedicine and virtual care technologies. Next slide. And the last piece of context that I wanted to provide for video visits that's important to know is that there are a number of requirements for a patient to successfully connect to their provider via video. And I've listed some out here, but these don't even include like the navigational pieces, the language pieces, etc. And so the first requirement is having a My Health Record account, which is a web portal that you can access through the website or app, and is what the video visit for the patient launches through. So that's what patients are using to connect to their provider via video. And the remaining requirements are listed there on the slide. So a computer, laptop, or mobile device, a reliable and secure Wi-Fi internet connection, a front-facing camera or webcam, a microphone, and speakers or a headphone. Next slide. Thank you. So this is very briefly the process that we used. We started out with a rapid literature search to identify existing frameworks we could use to assess video visits from an equity perspective. We found two really excellent frameworks, and using those two frameworks, we created a framework hybrid to use for our assessment. From that framework, we developed a list of guiding questions that we then used to create a list of recommendations for the women's virtual department. Moving on to the framework. So our framework is actually, like I mentioned, a hybrid of two existing frameworks, and it was adapted from Wur, Sinha, and Catalani, and Veno, Mitchell, and Anchor. And the next slide has our framework on it. So here you can see that this hybrid framework included the scope of the initiative, so looking at the populations and communities of the patient users, the determinants of health for key patient populations, and the steps required to accomplish a successful video visit. We looked at potential impacts, so inequality in access, uptake, adherence, and effectiveness, mitigation techniques, so precautions in access, uptake, adherence, and effectiveness. And the other two pieces of the framework are monitoring and dissemination. And just so that we're all on the same page, I'm going to quickly define what I mean by access, uptake, adherence, and effectiveness. So inequitable access occurs when interventions are made available through channels that are not equally available to all. Inequitable uptake or adoption occurs when the initial use of an intervention is delayed or never occurs among certain populations as a result of systemic barriers, such as income inequality, structural racism, a deficit in social capital, lack of trust in technology, etc. Inequitable adherence to interventions occurs when certain populations are unable to continue utilizing an intervention due to systematic disadvantage. So adherence may be higher among advantaged groups because of usability and literacy related demands, along with better access to money, time, and coping skills. And lastly, effectiveness of interventions is inequitable between populations when they target individual behaviors as opposed to the upstream determinants of health. Next slide. So possibly the most interesting part of the presentation is our list of recommendations. And so what we did was categorize these by patient, provider, organization, and technology. And then we also created a decision tree for providers to use. So I will say that the value in our recommendations really lies in their specificity. However, many of them felt too detailed and technical for the purpose of this presentation. And so I've grouped many of them together so that you get a sense of the general themes that emerged. Next slide. So these are the recommendation themes on the level of the patient. The first was around making it easier to select and change gender identity, so having a more diverse range of options to choose between, and then also allowing patients to independently change their gender identity without having to connect to a person at the hospital to do it on their behalf. The second theme was around getting locked out after failed login attempts, which is something experienced very often by our older patients. The fact that in order to get My Health Record, you do not need OHIP, and so we felt like that needed to be made very, very clear for our refugee patients and for folks who might have IFH coverage, interim federal plan coverage, and to display the support phone number and email address very clearly on the website when patients are trying to access it and use it. And last but not least, providing multilingual and multimedia information resources. And this was one of the biggest recommendations because when it was created, those instructions were only available in English. And so for our non-English speaking patient population, it was critical to support them and create some kind of multilingual information resource that was available both through video and PDF, especially for for folks that might have more limited literacy. So next slide. On the provider level, there were 3 themes of recommendations. The first was to ensure secretarial staff, clinicians, and women's virtual support staff are trained to identify barriers to virtual care utilization and implement strategies to overcome them. The second was to ensure decisions regarding when to use video visits are based on patient choice and safety, which is a very big one and an important one, because we wanted to make sure that patients have a say on whether or not they are able or willing to have a video visit. And lastly, to ensure secretarial staff, clinicians, and women's virtual support staff are trained on when and how to use phone interpretation line. So again, making sure that we're supporting our non-English speaking patients. Next slide. And then on the organization level, again, 3 general themes of recommendations. The first was to create programs to support patients who do not have access to the required digital tools or essential technological aids in order to have a successful video visit. The second was to be an advocate for the technology platforms that we use to be available in multiple languages. So in our case, that would be My Health Record and also Zoom. And lastly, to ensure that there is ongoing technical support available to troubleshoot issues. So when patients run into issues with their video visits and launching those, because it does require some, like I would say, a medium to high level of computer literacy to make sure that we had folks on the ground at the hospital or now remotely to help support them through that. And next slide. Sorry, next slide.
Shivani, does it not appear to be advancing?
Not on my screen, no. Oh, now I see the title slide. Yeah.
And
Thanks,
would you
Jay.
like
and then
technology?
Just one more. Oh, I'm sorry. Yeah. Yes, so sorry. So for the technology recommendations, there were 3 general themes. So the first was that the My Health Record website and application should be available in, at minimum, the top 5 languages spoken by hospital patients. The second was to make sure that we are including patients in the iterative design of this program, which may change. And so we want to make sure that we continue to engage them. And lastly, to ensure that health information that's conveyed in My Health Record is easy to understand and interpret for patients who are accessing their information. Next slide. So now I'm going to be talking about the decision tree, and I know that this looks like a very busy slide and it looks pretty complicated. And so I'm not going to read through the entire slide, but essentially we've listed out key considerations for providers to think about when implementing video visits with patients. And the issues to consider are grouped under infrastructure, privacy and confidentiality, suitability, and cultural relevance. And underpinning all of this, of course, is always patient choice and safety. And so the value of the decision tree might just be in encouraging providers to think through all of the issues that are listed here, as opposed to having them walk through the decision tree in every instance, especially because, you know, we acknowledge that providers may not know the answers to many of these questions for all of their patients. And so that's the end of the equity assessment. Now I'd like to hand it over to Jen Rayner, who is the Director of Research and Evaluation at the Alliance for Healthier Communities. Oh, Jen, I don't hear you.
Sorry. Jay, if you could just, thanks Shivani, and if you could just go to the next slide. I'm just conscious of time. So I wanted to spend a moment just introducing the organizations that I'll be talking about over the next few slides. I'm representing the Alliance, and we support 100+ comprehensive primary care organizations in Ontario that have all adopted a similar evidence-informed model, which we call the model of health and well-being. And really all this is a roadmap that outlines how services are provided in all of our organizations. And the organizations I'm going to be talking about today include community health centers, Aboriginal health access centers, nurse practitioner-led clinics, and community-governed family health teams. And you may have heard a common adage about a community health center, that if you've seen one community health center, you've seen one community health center. And this is very true, because they're built by and for the populations they serve. So often the services look different, the types of providers they have look different, but the roadmap is still the same. Everyone has interprofessional teams, they're grounded in community development, and they're based on determinants of health, health equity, and an anti-oppressive lens goes through everything we do. And the populations served are often those that experience like barriers to care, which might be people living in poverty or experiencing homelessness, newcomers with language barriers, people that are experiencing racism or other systemic barriers. So what they have in common is significant at this model, and I think you'll see that throughout this conversation of how we implemented digital and the issues we found with using digital during COVID. So next slide. So as soon as the pandemic was announced, a small team, including myself, wanted to check in with all of our members to understand what they needed, both from a policy and advocacy lens, but also to gain an understanding of how they were serving their communities. We knew prior to these calls that this pandemic would only highlight and perpetuate inequities that already existed, and that people living in poverty, those who are racialized or living in congregate living centers, would be adversely impacted. And we also knew, like you knew last year during our symposium, that digital equity was important and real, and that this fast forward into a virtual care model was not going to work for some. And it would work for some and not for others. And often places where it wouldn't work are those that healthcare often fails to reach generally. So this was an informal call. It wasn't research. It was just an informal call. We did use an interview guide, but it really allowed the conversation to be free-flowing, and we wanted to learn from centers and have them be able to help other centers learn from what they were doing. So I'm going to be discussing a few of the findings we found in this, which led us to our research project in more detail. But right away, Alliance members talked about the inequities that their clients were experiencing. And as the world went virtual, people without access to phones, private spaces, or Wi-Fi were shut off from accessing care this way. So we heard this from Ciro, exactly what she talked about. Many people required primary care services, and so a lot of our organizations just could not shut down. They couldn't offer virtual care to some people, and we had to keep providing primary care. So the calls also raised huge basic needs. People were suffering, and within the first couple of weeks, 80% of the CHCs were providing food to their clients and communities. The organizations described really amazing innovation, and health promoters and other staff were conducting wellness checks, including people who were socially isolated or clinically at risk. And finally, many organizations realized that not only did their primary care services need to be continued, but there was a huge importance to keep people connected through health promotion and social support. So I'm going to talk a little bit about that. So I'll be talking about all of these in a bit more detail, and really and this is what led us to really try to do a more rigorous research project aiming to understand how the shift to virtual impacted client care, focusing on the inequities that people experience through this digital transition. So next slide. So we heard from our members that primary care really didn't skip a beat. It was somewhat easier for our organizations. They didn't require a billing code. Everyone is on salary within our organizations. So for many centers, they offered a combination of on-site and virtual because people couldn't all have access. Virtual care services included chronic disease management, sort of the ongoing primary care, included palliative care, counseling, dietitian visits, physiotherapy, and other types of one-to-one service delivery. We continued to learn from each other, and we offered lunch and learns. So we've got lunch and learns on how to do physiotherapy virtually, how to do dietitian visits virtually, and we really learned from each other because it was so fast-paced. In addition, what was discussed in these organizations is that they were finding significant gaps who could access care. So again, you won't be surprised, we've heard it already. Our members weren't surprised, and they really had plans to mitigate this digital barrier. And how they did that is many CHCs organized phone drives, they reallocated funds to purchase phones and data plans because virtual care was inaccessible. The Alliance and members solicited corporate or donations, and they kind of shuffled budgets to try to deal with this emerging need. And what the other concern was is that people that didn't have a private space, and so that, you know, this was talked about earlier, having that private space for people to have a privacy to talk to your provider was a luxury that you know, many of our clients didn't have. The other recognized gaps, which I think are more commonly heard, are, you know, people in the northern or more rural areas. Broadband just doesn't work as well, and it's not as reliable, maybe sometimes not available. And then the overall digital literacy that a lot of people experience, where they just didn't feel comfortable. And this ranged across clients and providers. So for many clients, digital was just not an option, and all of our organizations had to continue working, and they went out and did more outreach. So they were working in shelters, hotels, or redesigning their clinic spaces to ensure that they could provide care for when virtual wasn't accessible. Next slide. So like I mentioned, addressing basic needs was a priority for most centers. Food security was such a massive issue. I won't talk much about it because we're talking about digital, but this is just a picture of one of our centers providing takeaway meals. Over 80% of the organizations I work with had to provide food hampers and takeaway food for their clients and communities. You know, I think, again, one of the basic needs we found right away was that people needed mobile phones and data to stay connected. So this wasn't just with primary care, but to stay connected with their communities and people they normally worked with. You know, many of our clients, like was discussed before, relied on Wi-Fi in libraries and coffee shops, and they were now without this access. So we made sure they had access where we could. Next slide. Another thing that was done quite early on is many of the CHCs generated lists of clients using their EMR just to flag people who they were really worried about. And these weren't just due to their health status. Often they were, but they were also people that were at risk of being lonely or in social situations that might require some support. So these were often done by calls or video check-ins, and providers would identify their needs, and they'd try to preemptively help. So this was COVID related, but it was also a real-time risk assessment, really, where people needed food, or they needed some health care, or they needed some social support. And these connections were made, and they're still being made on a weekly or bi-weekly basis. Next slide. So one area that required quite a bit of innovation was to redesign all of our social support and health promotion programs. Many CHCs quickly redesigned these, and there were some real innovators, and programs included yoga, exercise classes, LGBT connections, seniors programs, homework clubs, social support chat rooms, cooking demonstrations, and even art therapy. Some people, and Sarah's going to talk a little bit about this, noted that providing virtual care actually increased access to programs, and many are hoping to continue to provide this option if and when it worked well. And this is one area where we also took a really rapid learning approach, because there was a bunch of centers that did this right away and caught on and transitioned their programs well. So we've got a lunch and learn, and we've developed a community of practice for all of the health promotion folks that are doing work like this to come together and learn from each other about how to break down barriers to continue offering these groups. All of the barriers for social engagement and health promotion programs are the same. Lots of people can't access it due to barriers, reliable Wi-Fi and the learning curves. We're definitely not able to access this type of service. Next slide. So, because of all of that, we found that like for everyone, we sped up our virtual care really quick due to COVID. I'd say we'd been tinkering with virtual care prior to COVID, and we knew that gaps existed, and also we imagined the possibilities. And I think COVID really threw us into this modality quickly and without any extra resources. So about 2 months after COVID was first announced and we started providing virtual care, I started receiving calls from executive directors and clinical directors asking to formally evaluate and research the impact of this care. And at the Alliance, we're really trying to reinforce a rapid learning culture. And the executive directors and clinical directors really caught on to this, and they said, we want to learn what worked with whom, how, and when. They noticed some benefits. They said there's fewer no-shows. They felt that for some people and for some conditions, they were able to see more people. But we knew there were these equity gaps. So how could we learn, and how had anyone been able to mitigate these gaps? We knew that some providers absolutely hated virtual and they wanted to get back to the office, but others, had really adopted it well. So why was this? And we knew for some people that virtual removed barriers, so they didn't have to worry about transportation or other costs. So we embarked on this sort of really formal project to understand the impact of this fast track into the virtual world. And it's really morphed into a bit of a program of research, because we're going to be looking at multiple types of service delivery. And as Jay mentioned, the other piece of work we're doing at the Alliance is really around policy work. We want to build a strong foundation, and we do recognize that digital access is a determinant of health. And this is going to be highlighted by Jay at the end of the talk. So I'm going to turn it over to Sara. She's going to talk a little bit about the work we're doing. We're very much in preliminary stages, so it's all early results. Thanks, Sara.
Thanks, Jen. Hi, everyone. So using the quadruple aim as our framework, our virtual care study is going to really describe how virtual care was implemented for COVID-19 and what were the facilitators and barriers in doing so. Our study will also understand providers' experiences with virtual care. So why was it that some providers had an easier time than others with transitioning care? And can we figure out why? And same with clients' experiences, exploring whether or not they were negative or positive, and if certain populations have a better time with virtual care than others, and if there's certain characteristics that may lead to that. And then using that data to make some recommendations for continuing some aspects of care virtually post-pandemic. Next slide, please. So the data we'll be collecting includes an organizational survey. This includes characteristics of our centers, so the rurality, when was a center established, their staffing structure. We've identified which services they offered virtually, which platforms they used for which service, what steps they took when they were transitioning care, some of the implementation challenges in doing so, and which populations experienced the greatest amount of challenges. From the EMR, we'll be pulling all the clients who have received virtual care, so either phone calls or care through video calls, their sociodemographic data, so their age, gender, income, race, ethnicity, household composition, education. We'll also pull what services were provided to them virtually and which platform. And then we really want to explore if there's changes in the number of appointments being made and the number of clients being seen as a result of going virtual. And then the qualitative aspect of our study includes interviews with providers and clients, because we really want to hear about their experiences with virtual care, their perceived limitations and benefits, if they prefer a certain platform or a modality more than another, and if they're interested in receiving care virtually from the client perspective, and then for providers, if they're interested in delivering care virtually. Next slide, please. So now I'll talk about some of the super preliminary results we've had. So from our organizational survey, we learned that a little over half of our centers responded that they were reasonably prepared to offer virtual care. And some of the major implementation challenges they experienced included Wi-Fi and internet connectivity, IT capacity. So those centers who had IT personnel on staff had an easier time than others. Security and privacy concerns around which platform to use for which aspect of care. Funding for technology, so purchasing laptops for staff, webcams, virtual platforms, and even extended data and phone plans for providers. And then also staff readiness, because of course some providers were more comfortable transitioning care than others. And then the populations who experienced greatest challenges, our centers identified seniors, mental health and addictions, people experiencing homelessness, newcomers, and people living in poverty. And so for all these groups of individuals, access to technology and proper internet connectivity were the biggest challenges. But more specifically, for seniors, it was whether or not they were comfortable using technology and receiving care virtually. For mental health and addictions, people experiencing homelessness, and people living in poverty, it was more around privacy concerns. So did they have access to an area where they could receive care confidentially and privately? And then for newcomers, language barriers became even stronger. So this really highlights why we need a digital equity agenda. Next slide, please. From the EMR, we also pulled super preliminary data just to look at the difference in percentage of in-person appointments versus virtual appointments. So before the pandemic, we can see that in-person was offered way more, but then as the pandemic started and continued, there was a switch. There was obviously more virtual appointments, but as you can see, our centers continue to offer in-person appointments, and that's because of all the barriers our clients face. And so we needed to maintain access to services. Next slide, please. And then from our interviews, what we learned from providers is that the greatest challenge to virtual care is the inability to read their clients' body language. So to see how their clients are responding to what they're saying. And so this was a greater challenge for newer clients that providers were seeing. For regular and repeat clients, this wasn't as much of a challenge because they had that client-provider relationship, so they could detect changes in the way their client was responding. But for newer clients, they hadn't established that relationship yet. There were also privacy concerns for individuals who couldn't find a quiet place to receive care. Distractions was also another concern, and providers hypothesized that because clients weren't physically coming to the center to receive care, they found that phone or video calls was more informal. So some providers had clients accepting calls like while they were grocery shopping or washing the dishes or having side conversations. So it was difficult for them to maintain their clients' focus during the appointment. However, in regards to access, clients with social anxiety really preferred virtual care because they felt so much more comfortable receiving care in their homes. And those with limited transportation options, the cost of transportation was a barrier. Those with limited mobility, they also preferred virtual because it just increased access for them. Providers had less cancellations, but they did have to call multiple times due to them using their personal phones and then having to block their numbers, and clients were more reluctant to answer a private number. So to mitigate that, they would have to leave a voice message saying, "This is so-and-so, I'm calling about your appointment." And then they would call back later and then the client would answer. So overall, majority providers were more than likely to offer virtual care in the future, but they did say that they would prefer the initial visit with new clients to happen in person so they could establish that client-provider relationship, build that rapport, and then have the subsequent visits virtual. For clients, for a majority of the clients we interviewed, it was their first time with virtual care, and they very much preferred phone over video because of all the technical issues they experienced, whether that was internet connectivity, finding the invitation link, setting it up, having a proper webcam or technology to use. Some clients also found it hard if they were talking to their social worker or mental health therapist to discuss certain topics over the phone. They would very much prefer either having a video call or talking in person so they could read their read their provider's body language. And then with access, those with young children really preferred virtual care because then they didn't have to arrange childcare or they didn't have to take their children with them to the center. And then some preferred in-person care more than virtual, but they did like having virtual care as a backup in case they couldn't make it in. And likewise with providers, they did prefer in-person for their first appointments. So this kind of just summarizes some of the early results we are seeing, but we are going to be doing a more in-depth analysis when we have collected all our data. And now I'll hand it off to Jay, who will talk about some of our policy recommendations.
Hello, video's on, good. Okay, so, we're right down to time, and apologies that we took up some time at the beginning of the session to get sorted out. But I think, we'll get right up to 5:30. I only have 5 minutes to talk about these final policy recommendations. And then my suggestion would be that we call it at 5:30, but our final slide does have an email address that you can send any questions or comments, and you can also reach out to us on social media, Twitter, other strategies. There are other strategies for you to connect with us as well. So the next steps on policy that I'll be discussing come from 2 different domains, as we've discussed a little bit. Some of them come out of the policy symposium, and the discussion paper that we're reporting on today. Others come from ongoing advocacy work that the Alliance is doing. So the work of the Alliance falls into really one of the kind of core categories of recommendation. So I'll refer to these 2 together first. So, our first next step for policy that we identified out of the symposium was this: to invest in approaches that address the digital divide. And, although that's elaborated for the Ontario context, the Alliance has, produced a fairly comprehensive set of recommendations related to advancing this work, in Ontario, but also across Canada. And that's based on a few kind of key points. So 1, the internet is an essential service and access is a right. 2nd, develop a pan-Canadian approach to digital inclusion. This is work where there are these kind of offshoots of really interesting innovation happening in that regard, but as of yet, there's no pan-Canadian approach. So this is something that the Alliance has put forward as really essential, particularly given recent experience. A 3rd is to legislate for low-cost options, and they specifically refer to the CRTC regulating telecommunications providers to ensure that affordability doesn't interfere with the ability to have entire populations benefiting from the use of technology. And then last, to provide access to digital skills training in a meaningful and comprehensive way. So those were kind of some key insights that the Alliance has developed to advance this notion of we need strategies to address the digital divide really on a pan-Canadian scale. So other recommendations for policy that were focused more specifically on Ontario arising from our symposium were, so 2nd, to support the design and procurement of digital health technologies in ways that support health equity. So, this of course involves inclusive or universal design, which we've already discussed. Shivani outlined in detail one approach to accomplishing that with Women's College Hospital. Another concrete example is to look at the digital health playbook that the Ministry of Health produced for Ontario health teams to build into policy guidance like that, strategies to ensure that digital health technologies are equity promoting. A 3rd next step for policy is to incorporate equity considerations into the review of health information policy. This is, of course, something that's been of great interest recently, especially around the collection of sociodemographic and specifically race-based data in the context of the pandemic. And health information policy is evolving. There's review of existing health information policy in Ontario and internationally. And it presents an opportunity to dig more deeply into understanding whether the changes to health information policy lend themselves to an equity enhancing agenda. And then 4th and finally, to continue to invest in strategies to address complex needs and the social determinants of health. And this is the point, to not become too narrowly focused on technology as a solution, but instead to understand that there's this broader work happening and that work remains urgent. And this is something that we've heard from a number of our speakers, and especially from our colleagues at the Alliance, about the importance of that in-person care. and to see how in-person care actually has begun to climb back up in terms of the proportion of care represented. So very important. I'm going to pass it over to Catherine to kind of conclude things. So Catherine, over to you.
Thank you, Jay, and thanks to you, Shivani, Ciro, Sara, and Jennifer for sharing your knowledge and experiences with us today. We are out of time, so we will not be able to do a live Q&A. However, you are welcome to submit your questions and comments to the Weave and Joint Center for Bioethics team, and they will make sure that they get to the appropriate, that they get sent to the appropriate presenters. So please don't consider this conversation over. There's definitely lots to keep talking about. And as a reminder, this webinar has been recorded, and we will be sharing it along with the slide deck on the Joint Center for Bioethics archive page. Thanks especially to everybody then. Sorry, I'd like to also thank Jordan Benedetta from Women's College Hospital and Lori Bilchak from the Joint Center for Bioethics, who provided support with logistics and communication for today. And I especially want to thank all of you in the audience who joined us today. And I hope that you found this session enjoyable, informative, and inspiring. Have a wonderful evening.